Okay, so thank you for having us today. I'm in the lab, and next to me is Dr. Abe Schlotteroff, who is spending the year with us. He's one of our spine fellows. Abe is actually originally from Washington, Preston, right? Shelton, that's right, Shelton. Shelton, Washington. And he did his residency at Penn State. And he came and spent the year with us, and is now going to go to Idaho Falls, where he's going to join a great practice. And we've actually done a lot of minimally invasive stuff this year.
Minimally invasive stuff, yeah.
So we're going to actually do a very cool procedure today in the lab, and something that I'm very excited about. And Abe, I think we've had tumor trauma patients on our service. For trauma, I would say that, I kind of see doing percutaneous, minimally invasive, vertebral augmentation, kyphoplasty, vertebroplasty, and now with newer devices that have come out, and one in particular that I'm very enthusiastic about trying today in the lab, it's called the spine jack. And basically, it's a titanium implant, and Reagan here has got some for us. So, Abe, go ahead and grab that. And then maybe what we can do is let's zoom in on, and we'll actually expand. I think we have enough to expand. So this one is, I think it's a 5 millimeter, and it comes in 3 sizes. So I actually wrote this up. So we're going to do today in the lab, we're going to do we're at about T6, T7, and T8, and we've already put the Jamshidi needles in. Dr. Schlotteroff did a great job. So we have bilateral Jamshidi needles at these levels. We're gonna show you guys how to create the cavity with the balloon, and then we also have a curette that we'll use and at the next level, and then we'll also put the spine jack at the level below. So we've got T6, T7, T8. And then we have the small version, which is used in upper thoracic spine. And then the medium version, probably like mid-thoracic spine. And then the larger version for the lumbar spine. So we've got the medium one. For me, what's nice about this is that, and I think, Abe, we've done some cases where, you have an acute pathologic fracture, like a tumor or someone with osteoporosis. Usually the end plate buckles.
Yeah.
And so to be able to have a device where you can actually restore the height of the vertebral body, I think is important. And I think this is where this device really is able to do that, is to get that, superior end plate and sometimes the inferior one, but I think it can be really useful. And so now we're gonna go ahead, and Abe is gonna go ahead and expand this. And you guys can see how nicely this expands. And this is the 5 millimeter one. And Abe, tell us how is it very easy?
Yeah. Very user friendly, yeah.
And then you can see there, basically what it's doing is as Abe twists it, it pushes the device, and then I think at the end it kind of basically maxes out.
Yep, right there.
And then that's how it looks on it, like a sagittal view. And then if you turn it around, you can see how thin it is. And so you would put this in bilaterally. So that's what we're gonna do at the T8 level. And that's what the spine jack is. And again, just because we're at T8, we'll use a medium one. And then I don't think you can, once it's inflated, you can't deflate it. So let's go ahead. So Abe, why don't you go ahead and put, so now we've got the Jamshidi needles in. So we're gonna go ahead and now replace that. Let's go ahead and put, no, this one we're gonna do just a cavity curette creation. And Abe will show you, this is the curette. This is a very nice curette that they have. So Abe, show the tip of it. So again, if we can just focus in on, actually just put it right there, Abe. And then we'll get Ben to try to focus in on the curette. And then it's got a dial so you can make it longer and extend it. There it is, perfect.
Tip there.
So you can, so once you turn the handle, so that's what's gonna go in. So let's go ahead and put it in at the T6 level. And then you can see that little knob just extends it. So Abe is gonna go ahead and put that in, and then Angela Tran is gonna get a nice x-ray for us here. And what this does is basically, it's like a little hook, and it goes in, and you're able to turn it around, so it'll create a nice little cavity. So let's go ahead and let's see what that looks like. And then Abe's going to extend that and then
Shoot
push
that.
it down. You can see
Go
it
down
coming
towards
out.
feet a little bit.
There you go. Now go ahead
Shoot
and
that
turn
one more
it.
time.
Good. Shoot it again, Angela. Perfect. And then turn it a couple times. Can you feel it kind of creating a little cavity there?
Oh, yeah.
Okay.
Shoot
so, perfect. And then maybe let's just do a quick AP. Abe, just go ahead and let's go ahead and turn it. Let's see. Maybe go live. Let's just see what it looks like under AP. And the cement that we're going to use is PMMA, and it takes about less than a minute to mix it, and the working time is about 20 minutes. So you kind of want to have everything ready to go before you start mixing it, because it sets pretty quickly. Yeah, go ahead and shoot that, Angela. Perfect. So you can see that, and then Abe is going to go ahead and push it down, and then let's go and get a shot there. Let's just do a quick live.
You want to do live?
Yeah, let's just do live so we can see that thing move around. Awesome. So you guys can see that turn around. Okay, perfect. And then let's go back to lateral. And then what we'll do is we'll just leave that there for now. And then let's go to the next level. So we just did the curette and created the cavity. So theoretically, we could put cement in there, because Abe has now created that little cavity. Because what you want to do is you want to have the cement interdigitate with the fractured bone. And then now we're actually going to use balloons. And these balloons actually they have contrast in them. And so we'll be able to inflate the balloons, and probably about 4 cc's is what they recommend. And then we'll see what it looks like on the lateral. Great. And that's the little drill that Abe used to put that in. Perfect. And then maybe do the same thing on the other side. And then that creates a little cavity. So we could use the osteotome again, just to clear things up. I personally think it's really up to you. I think if you've got soft bone,
Shoot that.
you could use that curette. So Abe, what do you think? Should we use the curette, or do you just want to just use a balloon?
We can try the balloon.
Okay, let's try the
try
balloon. So we're gonna put the balloon in, and again, he has a little. You can see that there. He's got a little device that he's holding, and then you can see the tip of it, and so he's got to go. So can you guys see that there? So the tip is, so there's 2 dots. There's a posterior and anterior dot. And so that's perfectly placed. You want it to be mid-vertebral body. And now he's going to inflate it. And it's about, 4 cc's. And then it has contrast in it, so we'll be able to see it blow up. So let's see what that looks like. Terrific. So that's perfect. And then why don't you leave it inflated?
Okay.
Let's do the same thing on the other side. So we have so we've got 2 balloons. And I believe it'll stay inflated. So you can disconnect it and put it on the other one. Yeah, it should just come off. And you can see it's got a little valve in there. So it's probably under pressure. It's leaking a little bit, but it's and how many cc's was that, Abe?
Shoot
about
that.
4? Did we start at 10? Okay,
about
that was
3
about,
cc's.
okay, perfect. So we're going to do the same thing, and then we'll do a quick AP once.
Shoot
and
that.
you can see he's trying to line it up. So maybe put it in a little bit more, but it's not going anymore. That's fine. Let's go ahead. So you got to get that.
Shoot that.
It might need to go in a little bit more, Abe. You want to deflate it?
Yeah.
Why don't you deflate it?
Drill a little deeper.
Yeah, probably drill a little bit deeper. And this is where, again, I think it's a great time to maybe put the curette in there if you feel like you need a little bit more room, but go all the way down if you can.
Shoot that.
Okay, I think that's probably good, huh?
Yep.
That's much better. Perfect.
Yeah, as far as that's going.
Okay, so now, again, so you're doing, basically, we're creating that cavity with the balloon this time instead of with the curette.
Yep.
And then once we get everything set up, then we'll mix the cement because it doesn't take very long. What you don't want to do is start mixing the cement now because then it'll harden by the time you go. So how did that feel? Could you get a little resistance?
Yeah.
So Angela is going to get us a nice AP. And again, when you're doing like upper thoracic spine, you really want to try to get a good view of the end plate. So I try to square up that particular end plate. So like for T7, it'll be different than T6 and T8. That looks pretty good, Abe. So you can see there, the end plates are pretty crisp. Okay, and then let's come back around. We probably could inflate it a little bit more. But you run the risk of the thing rupturing too, so that can happen. So we'll go ahead and, let's see. Usually, it kind of, once you fill it to the point. Okay, so now go ahead and, so we'll take that one out and then deflate the other one. And then to do and the reason why we're going in this sequence is that so you guys can see the steps. So in order to insert, so the next level we're going to do is we're going to do the spine jack. And what's a little bit different with the spine jack is that there's a larger drill that you do, and then you take out, so you put it like a Steinman pin, put it actually in this one. We'll do the spine jack in this one.
Spine jack?
Yeah.
No, okay.
Yeah, and then we'll just fill the other one with cement. Yeah, spine jack on the bottom level. So turn that one. There you go. And so you do have to drill a little bit more, and you have to create a larger cavity. So in this level, so basically we just did the balloon. So that's how we created that cavity. And then in this one, we're going to use a drill to create the cavity, and then it's got a little trocar. So you can see that there. So let's go ahead and you can just mallet it a little bit. There you go, perfect. Just to get it in a little bit further.
Yep.
Great. And then now what you can do is take out the jamshidi, and then we'll slide. And it's almost like putting in percutaneous pedicle screws. So the trocar protects the drill. So there's a little trocar that goes over the top. And so that protects the drill from getting caught up in this tissue. And then there's I call it it's a template or a bone tamp that you can use. So now Abe is going to go ahead and place the trocar first, push that all the way down. And then now you can just drill through that.
Shoot that.
Great.
Yep. Yep.
And you can really feel the bone, right? Because you're basically going through the pedicle. You're drilling through the pedicle and then going into the vertebral body. So Abe started out here, and now he's mid-vertebral body.
Okay.
Yep, and then Abe, you really have to drill down on that. So make sure you're all the way down, perfect. And it has to go
all the way?
All the way in if you can, perfect. And then now take out the drill and leave the trocar. And then we'll do the same thing on the other side. you can see, let's show the audience how much bone is in that drill. So you can see there, it got quite a bit of bone. So then we'll do the same thing on the other side, and then there's another drill. Or could we'll just use the same one, huh?
Yep.
Okay, good. And then probably what I try to do is think about, do you need a little
Yeah, a little
knife?
bigger incision.
Here. Is once the spine jack is in, then we'll mix the cement. Otherwise, you're kind of racing, and sometimes you have to redo the drilling, and until you're really ready to put the cement in, I would just hold off until the very end. Great. And you can really feel going through that bone, huh?
Yeah.
Abe?
Oh, yeah.
So
Powerful.
it's like putting in a pedicle screw, basically. And they actually use this in Europe a lot. There's a lot of good data that's come out, in Europe. And again, there's a lot of controversial evidence about, kyphoplasties, vertebroplasties. But for most surgeons and interventional spine physicians, part of the reason we do this procedure for tumor and trauma is to, I would say for us, it's make a diagnosis.
Yep.
And then the other is to treat the pain. And then the last thing is to prevent, I would say, progressive deformity.
Yep.
So, that's kind of threefold that you're doing this operation. It's not just for pain. It's also to prevent bigger surgeries and also to make a diagnosis, because you can, when you're doing this, obviously you can biopsy the vertebral body. And here, Abe is now going to, so that he placed the spine jacks, and now he's trying to dilate it up so you can see there. The bone's actually fairly hard here.
Fairly hard, yeah. Shot there.
So, great, you can see that. And when the bone is hard like that, you can see how powerful this device is. You can see it start to do, let's do the other side now. And then so now this is when we start mixing the cement. So, and then it just kind of stops after a while. So. Did it tighten up?
Yeah.
Okay, great. So you tighten up on one side, and then here's the other side. And then what we'll do really quick is also get let's get one more shot. Is that one almost bottomed out?
Yeah, they're both.
Okay.
They're both tight.
Okay. So let's do a quick AP. And then now what we'll do is, once we get an AP and we're happy with it, and there's not a lot you can do now. I mean, you can't take it out once it's fully expanded. But if you're concerned, for example, in this one, you go, maybe I'm not going to put cement. I'm afraid that it's going to leak. This at least gives you stability, and it distracts that inner space open. So you can see
Ferguson towards the head.
On the one side, it fully deployed, and the other one, it's about 3/4 of the way. And that happens. Okay, so now let's come back around the other way. And then what you can do is undo the device, but then leave the trocar in. And then you can just pull it out. Yeah, just the pin. Yeah, just pull the pin out. So sometimes it gets stuck.
Yeah,
just the pin, not that thing. Yeah. It's kind of stuck. There you go. Okay, perfect. So, and then do the other one as well. So just pull the pin if you can, Abe. And so now our cement's ready to go. So what we'll do is, so Abe, let's start at the top. So let's go ahead and start at the very top, and then let's get one more shot there, Angela. And you can see again, at the T8 level, we've got pretty good height expansion, and so he's gonna do the T7 level. I think that's cement.
Spine jack first.
Yeah, do that spine jack level.
Okay.
And then let's go ahead and go live. And then there's about, I think, 10 cc's in that. So we'll try to fill. And again, typically for most kyphoplasties, you know, most people do about a 1.5 to 2.
Yep.
If you create a cavity, it's usually a little bit more. It's like 2 to 5 cc's. And then come south.
Holding that down
this
so it
way.
doesn't come out.
Okay, good.
You might just holding that right
Yeah,
there.
yep,
Keeps
I
wanting
got
to
you.
pop out.
Okay, good.
Yep.
And again, when you're doing this cement, what do you want to look for, Abe?
Make sure there's no extrusion.
Exactly,
it's
and
not
vital
filling the
signs
venous-
too. So
yeah,
you
not
want to
filling
make
the
sure
venous
that
system. Shoot that.
you don't get any hypotension or any. Okay, so
Fine,
now let's do
CC.
that level.
Yep.
And then, so I'll take it out, and then let's do the next level. Where actually, let's go the other side. Go ahead and do that level.
Yep.
Great. You can see the cement filling the cavity there, and then let's go to the next level.
Yep.
Okay, great. So now we'll go to the level above.
A different one for that one.
Oh, yeah. We have to get a new, so that was, so it's a larger cannula, and then now we're switching the, so this is a smaller, great. You're good, Abe. Just go ahead and put it in and then start turning it. Perfect. So now you can see it's got a smaller,
Yep. It's a little deep.
yeah.
Yep.
Okay,
Shoot
shot
that.
there. Yep. Hold on one sec. Shot again. Okay, go ahead and do that now.
Yep.
There we go. Good. And you can actually
Yep.
see a little bit of it is leaking out the front,
Yep. Yeah.
but it's okay. So just keep going.
Yep.
Okay, good. And then
Other
stop.
side.
And then we'll do the other side. And then it's got a little, whoops, we had a little device there to hold it in place. Okay.
Shoot
shot
that.
there. So go ahead and fill that one.
Yep.
Shot there again? Okay, oh, actually, it's live. Okay, good. So now let's go to the next level. Let's go and do the, oops, let's do the top one. Okay, shot again. So, good. You can see that filling up nicely. Great. And then now let's go do the other side. How many cc's do you have left, Abe?
1 cc.
Okay, shot again. Okay, so we're gonna finish it up, and you can see again. Just I always
Final
worry
shot.
about anything leaking anteriorly, but more importantly posteriorly, and then we can start taking out the trocars. Let's go ahead and take out the trocars. Great. And that was fairly fast.
Yeah.
And then maybe just come over a little bit more, Angela. Just rainbow it over a little bit more. Great. So that's really nice. So you can see, again, at the T6 level, you almost got the entire vertebral body.
Yeah.
And then at T7, same thing. And then at T8, you've got a pretty good spread along the pedicle and mid-vertebral body. So that's really it. I mean, I didn't see any. Usually you see there's a tiny little bit of leakage. Actually, very nicely, you could see at the T8 level, there's a little vein.
A little lateral
And
spine jack.
that happens a lot, actually.
Yeah.
We get CT scans on every single patient, and it's amazing how there's always, basically the vertebral body is one huge vein, right?
Yep.
And it's got these venous channels, so you'll get leakage laterally, and fortunately, a lot of times patients don't have any problems. But intraoperatively, what are things that can happen, Abe? You can get
Vital sign changes.
exactly
Yeah.
hypotension. You can get pulmonary emboli,
Yep.
PE, and so when you're doing it, I always alert the anesthesiologist when you're putting cement in. But you can see, I mean, this is the cement. Go ahead and play with it, Abe. It's still kind of, it's still mixing, and it's like putty right now.
Yep.
So we still have time, and it takes about 20 minutes for this thing to set. So usually by the time you're out of the OR, this thing should be totally set. So that's it. Abe, any feedback from you? Like, what do you think about
that was
spine
great.
jack?
Yeah.
Have you used spine jack before?
Never used it.
Okay.
First time.
So
Mainly just cement.
yeah, I mean, I think again, when you're dealing with like tumor, pathologic fracture, especially with these older patients, and we've seen these together in clinic where you have like 6 fractures, and the levels I always worry about is like T11, T12, L1, thoracolumbar junction.
Yep.
And those patients, once they get 4 or 5, levels fractured, then they start to tip over. And for patients who, it's prohibitive, I mean, how are you going to do a fusion on them when their bone is fractured every level? So this is a great little...
Good alternative.
It's a great option. And, I personally think that this area is going to explode in the next, 10 or 15 years. And the newer devices like this one are really changing the way we're able to treat patients. So thanks so much. And look forward to seeing you guys back next year. And thank you so much to the team here at SSF for helping put together another great course and another great lab. And thanks to the course chairs and all the faculty. And see you guys again next year. Take care.